Okay, welcome everybody. My name is Virginia Wiseman, and this is, I think, the first skills building session for HSR. So we're very excited to be able to deliver this session for you, and we hope that it's going to be as interactive as possible. My name is Virginia Wiseman. I'm from London School of Hygiene and Tropical Medicine, and also the Kirby Institute in Sydney, Australia. And I join you from Sydney in the land of the Gadigal people, the Eora Nation, the traditional owners and custodians of this land. This session today, we have several aims. They were outlined already in the program for this session. Really, can we just move to the slide with the aims of the session, please? Thank you. So there's three overarching aims. The first one is to explain the standardized patient methodology and the different types of questions that it can help to address, both in terms of health policy and also health systems research. We're going to describe and take you through the main steps in designing an SP survey. And we're also going to weigh up the challenges and the opportunities that this approach can offer in terms of measuring quality of care in low and middle income countries. So what I'd like to do now is just take you through a few housekeeping rules. There's not too many, just a couple that I want to remind you about. So you'll see on your screen that there's a red icon in the top right-hand corner. This is live support, and we're very lucky today to have a few people from HSR who are guiding us through this process to avoid any kind of glitches or problems along the way. So do make use of that if you have any issues at all. There's also live Q&A, and this is where we're hoping that you'll post as many questions or comments. Some of you will have already had some experience using standardized patient surveys, and so don't be shy about sharing your experiences as well. I think the other thing to note is that the sessions are recorded. So I guess if you've got issues with that, then you might need to just take a moment and think about it. But we hope that everyone is agreeable to that so we can share these resources more widely. And in terms of the full screen, for your best experience today, it's best to view the session in full screen. Okay, so that's a brief introduction. Once again, fantastic to have you all here. And I'm now going to hand over to the co-chair of this session, Ada Kwan.
Hi, everyone. Good evening, good morning, and good day to you all. And thanks for joining us at all hours of the day. Thanks, Dr. Wiseman. So I am Ada Kwan. I'm a postdoc scholar at University of California in San Francisco. And we have a very exciting group with us today to talk about the standardized patient method. I myself am a health and development economist, and I examine drivers of quality of care in the scale-up of interventions. And the rest of the individuals in this room, we have many different researchers from various countries, such as South Africa, Indonesia, Kenya, China, and London. And so we have a pretty exciting lineup. Can we go to the schedule, please? And so Virginia and I will introduce the session as we've done, and we'll move into the first part of the skill building session, and where Jessica King from the London School of Hygiene and Tropical Medicine will introduce and tell you more about the SP method, the standardized patient method. In part two, we have an exciting hour session where we'll look at lessons from 5 different settings where people have done standardized patient studies. We'll hear about how the studies have been planned and how they've been designed and implemented. And we'll glean some lessons from these 5 settings in this session. We'll follow up with a Q&A, and if there's many questions, we'll extend this Q&A session into the stretch break, and we'll return at 11 o'clock Gulf Standard Time with a panel. The panel will be chaired by Kara Hansen from London School of Hygiene and Tropical Medicine, and we have 3 exciting guests who have conducted many standardized patient studies. And then Virginia and I will wrap up the session. Next slide, please. And for our first session today, we have Jessica King, who's a research fellow. Jessica is a health systems epidemiologist in the Department of Global Health and Development, and she focuses on statistical, mathematical, and econometric models and methods, and has done SP research in Tanzania in particular. I'll turn it over to Jess now for her presentation on how to do or not to do the SP method.
Thanks, Ada. I'm hoping you'll be able to hear me now, and I'll just start my presentation. Apologies. There we go. Hopefully my screen should be visible. So I'm going to talk today, it's great to see so many people online, about the standardized patient method and using it to measure quality of care, and then introduce you to a paper that a group of us wrote about how to do or not to do the standardized patient method in health facilities in low middle income countries. So firstly, a very brief introduction to quality of care, which is, of course, the whole reason we want to use the standardized patient method for quality of care measurement. It's a critical but sometimes overlooked element of universal health coverage. It doesn't appear in our lovely cube model, but without quality of care, access to care could be argued to be irrelevant, and it's been estimated that poor quality of care results in several million deaths a year in low and middle income countries. To think about measuring quality of care, we often go to our Donabedian framework for quality of care, which looks at structure, that is the inputs required to provide good quality of care, process, which is what healthcare providers do to provide care, so the interaction between the caregivers, the providers and the patients, and the outcomes, which are the sort of ultimate aim of care provision, so the health status. We often decide to focus on measuring process because structure, although important, has a very weak link with health outcomes, and outcomes, although the ultimate aim of providing healthcare, in fact, are a very noisy measure because they're affected by so much more than just the process of quality of care. And so it tends to be that we focus on these process measures rather than anything else. So I'd like to talk about a few alternative measures of quality of care first, other measures that we've used. And so the standardized patient is the one that we'll focus on this presentation, but it's worth putting that into the context of some other options, things like clinical observations, which is where a trained provider or trained field worker will observe the interaction between the patient and the caregiver, which is useful to capture everything that goes on in the consultation, but obviously is subject to things like observer bias. Clinical vignettes, so a field worker or provider sits with the healthcare provider who's being interviewed and asked, in this situation, what would you do if you were presented with a person who had a fever? What steps would you take? So a clinical vignette is a useful way of measuring knowledge, but not necessarily the practice. Then related to the clinical vignette, an observed simulated patient, and that's what we've got a picture of here in this slide of a doll there, which measures practice a little bit more than just asking the provider what they do, because they also sort of role play with that doll, but you still have the observer bias. And another couple of methods that can be used are medical record abstractions. So that's taking from the patient notes to try and work out if good care was provided. That's really tricky because firstly, you have to have good record keeping, but secondly, the skills of the provider, their ability to provide good care is going to be quite related to their ability to note down what's happened. And if the provider didn't make a correct diagnosis, then we'll have no idea because it won't be in the notes. And finally, exit interviews, patient exit interviews. So these are a really common tool that a lot of people have come across, but it's really hard to use them to measure quality of care. They tend to measure kind of patient satisfaction. And even if you do an interview that focuses on content of care, for example, from an antenatal visit to make sure that all the major things at an antenatal visit were carried out, it still relies on patient recall. So it's not a perfect tool, which is why there's been a focus recently on measuring the process quality of care with standardized patients. So I've got a few other words that we use for standardized patients: mystery clients, mystery shoppers, simulated patients, undercover patients. And so a standardized patient is a healthy field worker who's trained to present as a patient in a real world setting to seek care. And they originally were developed in medical education, so to train medical students who often might know that they're being tested by a standardized patient, but they've been more recently used as a research tool developed by economists and used in a real world setting. So providers, although they might have been asked in advance to consent to a standardized patient visit, won't know on the day that that patient visits that they are in fact a standardized patient. They'll treat them as if they were a real patient. So it's got some really useful advantages. There's no Hawthorne effect or observer bias. The provider doesn't know that they're being tested. We can control patient mix and case mix. So we choose the type of patients that we send to the provider. So that firstly means that there's not confounding. There's not a sense that different providers are getting different tests because of the different patients that turn up to their health facilities. We can make sure, the standardization part of standardized patients, that every provider gets the same test of their quality of care. And also it means we can examine care for rarer conditions, so something like tuberculosis, where if you were sitting in a rural health facility trying to observe a patient who had TB, you might have to wait for several days until a patient with TB came along, but we can send a TB standardized patient straight away. It allows us to benchmark against preset standards. So if we know what we're expecting, what the standard of care is for a particular condition, we can say quite definitively whether the care was good or not good. And then from a scientific perspective, it allows us to vary the type of presentation of patients. So we can have a patient who gives more or less information about their condition, or a patient who asks for a certain type of drug or doesn't ask for a certain type of drug, to see the effect that having this different type of patients has. And it's worth noting that double blinding is possible. So the provider is blinded to the conditions that we're using, as well as the standardized patients themselves, the field workers, who in, for example, a controlled trial won't know which facilities are control or treatment facilities. So this work on standardized patients has been put together in a paper that I mentioned before, How to Do or Not to Do, using the standardized patient method to measure clinical quality of care, which is another word for process quality of care, in low and middle income country health facilities. And the reason we decided to write this paper, so I worked with a team at the London School of Hygiene and Tropical Medicine and the Ifkara Health Institute in Tanzania on an evaluation of a very large scale quality improvement program in Tanzania. And we used 4 different types of standardized patients. And using them in health facilities is a bit more complicated than, for example, using them in a pharmacy setting or a family planning setting, because you have the provider can do tests or treatments that we want our healthy field workers to avoid. It's not a case of simply going into a shop and asking for a product. And obviously these providers will know if the patient, for example, doesn't have a symptom that they say they should have and isn't visible. And during the process of developing these tools, we asked for a lot of help from various different colleagues and thought it would be useful to distill everything that we learned and learned from others into this paper that's aimed at people who haven't kind of used this method before, and gives a step-by-step guide. And so one thing worth noting that I'm sure Ada will mention at some point is that we see this paper as a complement to a manual that's in the appendix of BMJ paper, which has a lot more detail about the exact methodology. This is a sort of introductory step-by-step guide. So I'll take you through the steps now. So the structure of the paper, apologies. First, we have choosing the appropriate SP cases, defining the correct management for those patients, designing the tools and planning the study, addressing ethical concerns, which is really something that has to be done all the way through, and training the field workers, organising field work, and finally assessing detection. Okay, so the first step, choosing a suitable SP case. There are quite a few considerations you have to make when choosing the SP case. You have to think about technical feasibility. So can this condition that you're choosing be portrayed by a healthy person? Are there some guidelines or evidence to say what correct treatment is? If you send in a patient with a complicated condition where you yourself couldn't describe exactly what correct management is, then you'll have a really difficult problem at the end of the study to say whether the providers did well or not. It needs to be something that's managed in a single visit. In terms of ethical acceptability, there are 2 main things to think about. The first is minimizing harm to field workers. We want something where the members of your team, the standardized patients, won't be subjected to, for example, invasive treatments or tests. And also it's worth considering the use of children. So some studies, for example, use an absent child to avoid using children in the actual fieldwork. So they have a standardized patient describe a child at home. And then finally thinking about the more scientific questions about the appropriateness to the research question. So does the condition of the patient answer something about the study objective? If in particular you're trying to measure the impact of a piece of work to improve quality of care for malaria, you need to make sure that the standardized patient will capture that. Do all the people involved in the study, the stakeholders, agree that it's a fair test of what you're trying to measure? If you want the results to be useful at the end of the study, it's important to make sure at the beginning that the providers, the implementers of any intervention you might be testing, think that this is a worthwhile thing to do. Do all of the health facilities in your study or experiment actually treat this condition? So an example from my experience was a lot of faith-based health facilities might not provide all types of family planning, which means we can use a family planning standardized patient. Are the conditions that you're testing actually a concern for public health or a clinical concern? There's no point in sending standardized patients who measure something that actually isn't particularly important to you. And finally, do the conditions that you're choosing suit local epidemiology? You don't want to choose something that is so extremely rare that providers won't have any recognition or likelihood of treating it correctly. Then there's not much point in sending those standardized patients. And so you can We often look at other types of standardized patients that have been used by previous researchers to decide on the sort of cases we want to use, and combine multiple types of standardized patients. And when I wrote this paper, I did a review of different standardized patients that were used in health facilities in low and middle income countries. And we can see here just a list of the types of standardized patients that have been used. So family planning clients are a very common type, partly because they're so easy to implement, but also because so many interventions have got to improve family planning quality. But we can see a lot of infectious diseases as well, things like upper respiratory tract infections, malaria and TB, as well as some non-communicable diseases, but they become less and less common, which sort of just demonstrates the focus of interventions really in low and middle income countries. So our next step is to define correct management. So this means that for every condition that you've decided to measure in your study, you need to pre-specify what actions the provider has to take to say that they have correctly treated the patient. And it's good to be able to use guidelines or a strong evidence base to say what correct management is. And you might want to do a sort of a composite outcome where a number of actions or inactions are required. And so I'll just show this example, which is an example of a TB standardized patient study. So a standardized patient goes in with various symptoms of TB, a persistent cough, and depending on the way we define good quality of care or correct management, if we say that the only thing the provider has to do is ask for some sort of TB testing, so they just have to say, oh, I'm going to send you for a TB test, then we had 17% of these patients getting correct management. But if we make a composite outcome, so we say that they can't have any harmful drugs, which we in this study were defined as quinolones or steroids, and that they have to suggest TB as a possible diagnosis, and they have to not give any other unnecessary drugs, then actually fewer than 1% of these standardized patients got correct management. So that's an example of where the definition of exactly what we say is good quality of care really has an impact on the outcome. So the next thing to do is to design tools and plan the study. So one of the most important steps is to do some preliminary observation in health facilities to understand the way patients behave and just the route of patients through a health facility, for example, where or if they have to pay, what kind of things the provider will ask a patient in your particular setting. And after that, you can write a script which needs to, as well as include details of their health conditions, sort of a history and biographical details, why the patient happens to be in that area. Develop a questionnaire for the standardized patients to fill in after their interaction with the provider. You have a few choices there. You can either have a self-administered questionnaire, which is easier and quicker, or a supervisor-administered questionnaire, which is seen as a sort of a higher quality check on what happened. You can do the questionnaire on smartphone or tablet, which again saves time compared to paper. And once you've developed all these tools, we start piloting, maybe with a provider who you've asked in advance and they're happy to do an open practice where you know that it's a standardized patient before going undercover. So there are a number of ethical concerns with standardized patients. So the first thing is, as I mentioned briefly earlier, the risk of harm to field workers. So we're sending healthy people to pretend that they're sick in health facilities, and so we're quite concerned about exposure to infections. In the particular context of COVID-19, I think it might be especially hard to justify the risk of sending anyone to a health facility. But we hope that there'll be a time again in the future where it's safe, but we still have to take a lot of precautions to prevent infections as well as other risks to field workers. And those can be prevented both through design, so through choosing cases which avoid, for example, invasive tests. So you might decide not to choose an STI case because of the risk of needing a gynecological exam, but also training field workers to avoid tests and other invasive procedures. So another thing to discuss is the ethics of sending mystery shoppers or undercover patients that providers don't know about. You can ask in advance for consent from each health facility or individual provider in the study for sending a standardized patient. Some studies have also taken the approach of getting a waiver of consent on the grounds that the services that the health facility provides are accessible to the public freely, that collecting the data has minimal risk to the providers themselves because any results will be anonymized, and that obtaining consent would increase the risk of detection, which would harm the study aims. So there are different approaches there that have been taken, and some internal review boards are happy to give a waiver of consent. Others have been less happy to, depending on their particular concerns about context. So now I'll move on to some more practical aspects. So training field workers. So you have to think slightly more carefully about the types of field workers you recruit for a standardized patient study compared to a normal study in health facilities. The gender of the standardized patient. Do we want to have only one gender doing each case or a balance? The physical and age, physical appearance can matter. And the language is spoken in different regions if you're doing a study across a large country, as well as making sure that that they don't have any underlying health conditions themselves that could confuse the provider and mean that your patient actually isn't a very clear case of what you're trying to portray. You'll want to then develop your script on the basis of the one that you've originally written, and it's quite an iterative process, and things come up that can be more complicated depending on the context. So often you go back and forth developing the exact sort of thing that a patient might say, as well as working out how the provider will respond to each prompt. And the final step that I'm going to cover is the detection survey. So it's a really important thing for validity. Most reviewers, if you write a standardized patient paper, will ask about detection because it's sometimes hard to believe that so few standardized patients go unnoticed. And the typical detection rates we tend to see in standardized patient studies are about 0 to 5%. And the detection survey can also be an opportunity to collect other data with the providers. For example, if you want to compare the knowledge so the provider's knowledge with their actual practice, you can do an interview with them on how they would treat a type of patient, as well as asking them if they've had any standardized patients. And so these are the things that we'd ask in a detection study. So if you suspected a standardized patient visit, can you tell us these details about the patient? And that's how we then try and define that patient as whether they were detected or not. This is an example from our Tanzanian RCT. So you can see that there are some standardized patient visits that I had to define as possibly detected, where the provider described a patient who was in some ways similar to the standardized patient we sent, but wasn't able to give us enough detail or a name such that we defined it as a confirmed detection. Okay. So having taken you through those steps, we've got a few final thoughts on research gender for standardized patient methodology, things that maybe we haven't been able to answer yet, such as can you develop standardized patient cases where the same field worker goes back for follow-up visits for more complex conditions? correct treatment is still a difficult thing to define. And can you give a different correct treatment definition depending on the type of health facility that you send your patient to? What should we do about false positive test results? So in a study that I was part of, we had a lot of false positive malaria tests, and should we be defining that as poor quality of care because it was incorrect, or do we accept that as random testing error? And another interesting question about power calculations. So if your standardized patients will vary in terms of their gender or presentation, that has an impact on the power of your study to detect differences in quality of care. So I'll finish there and stop sharing and pass back to Ada and Virginia. Thank you very much.
Thank you so much, Jessica. That was a great introduction to the standardized method and the certain ways that it excels as a tool to understand actual provider practice. Just touched on many elements involved in the development of an SP study, and you can, from what you've heard, you can understand that it's a little bit more complex than just administering a regular survey. And so we're seeing some really good questions already in the live Q&A chat online. And so I just want to remind you all to keep the questions coming. We'll get to these after the next session, which will be the next 60 minutes. Up next, we'll travel literally around the world to understand how different research teams have implemented the SP method. And we'll start with Dwayne Blau, who will talk about conducting an SP study in South Africa. We'll then move to Peter Mugo in the setting of Kenya. Xiaohui Wang will talk about SPs in the setting of in China, and Mulan Dari, who is based in Australia, will talk about an SP study in Indonesia. I'll wrap up the session, and I'll talk about a study that is ongoing in India. So I'll turn it over to Dwayne now.
Hello, everybody. My name is Dwayne Blau. I'm a researcher at the Center for Health Policy at Wits University in Johannesburg, and I'm going to be telling you about the planning and design of a standardized patient study we did in South Africa to investigate unnecessary antibiotic prescribing for respiratory tract infections in the public and private primary care sector in South Africa. The study objectives of our SP study were firstly to try and measure the rate of unnecessary antibiotic prescribing for respiratory tract infections by primary care providers in the public and private sectors. And secondly, we wanted to evaluate the impact of patient attitudes on unnecessary antibiotic prescribing. And thirdly, to look at the possible impact of financial incentives on prescribing by private GPs. The motivation for this work was that we have very high rates of antimicrobial resistance in South Africa, but most of the attention so far is focused on hospitals, so much less is known about what's happening in terms of antibiotic misuse in primary care. And in the literature, things like patient attitudes and expectations and financial incentives are some of the factors that are known to influence unnecessary antibiotic use. So why did we decide to use standardized patients in this study? I mean, the main thing is that unnecessary antibiotic prescribing is directly related to the no-do gap. That's most primary care providers know that they're not supposed to give antibiotics for viral respiratory tract infections, but in practice, they actually give out antibiotics. So we needed a methodology that allows us to evaluate actual practice. A second important thing is that we wanted to try and standardize the patient effects, and that's because very small or subtle elements of the patient presentation or their history might influence providers to give antibiotics, and we wanted to be able to standardize that, and the methodology allows you to do that. The third thing, as you will see, is that the SP methodology allows us to manipulate certain aspects of the presentation of standardized patients, and in this case, we used that to modify the SP attitude to receiving antibiotics and some financial aspects of the consultation. So a little bit about the background. South Africa is an upper middle income country that spends quite a large proportion of its GDP on health. That's partly because we have a dual healthcare system. The private sector serves about 20% of the population and is funded largely through private health insurance. The public sector serves the majority of the population and it's funded through general taxation. In terms of the primary health care, in the private sector, primary care is provided by doctors who are paid fee for service. And the patients fund those consultations through their private health insurance, or some choose to pay out of pocket to see a private provider. On the public sector, you're likely to see a nurse in a primary care clinic who's paid by salary, but the fee for patients is free. Services are free at the point of care. We did our study in one metropolitan city in South Africa, and we did that by visiting all of the municipal clinics in the public sector and by recruiting private GPs to participate in the study to represent the private sector. We spent quite a number of months planning the study. I think some of the aspects have already been summarized, but we spent some time defining the clinical case, which type of respiratory tract infection, specifying the actual clinical history and developing the script for the SPs to follow. And we also worked with local experts to decide on the appropriate management of our case and designing the checklist for analysis. A second aspect was really to try and understand how our SPs might access primary healthcare services in both the public and the private sector and what they were likely to experience when they did access those services. So we needed to know things like, would the providers see our patients if they just turned up off the street? Do they need to make an appointment? What sorts of information might be required at registration? How care was organized in those facilities, how long they might have to wait, which type of provider they might see, who was actually going to take their blood pressure, how medicines and prescriptions were organized, and what payments might be expected, which are some of the aspects that we had to understand in designing the study. And then we had to design the logistics. As I mentioned, we did some experiments, so we had to design the study for that. We had to decide how many SPs we wanted and what type of criteria we would require for them, which aspects we wanted to standardize, and also which aspects SPs we wanted to match. We had to come up with a complicated schedule to try and make sure that we visited all of the providers as efficiently as possible using our SPs, and we designed the data collection tools, which were done on a tablet. So this was the actual SP case that we used in our study to look at unnecessary antibiotic prescribing. So we had a case of acute bronchitis. All of our SPs were young and completely healthy, and they presented to the providers with a history of recovering from a cold, but that they'd had a persistent cough for 1 week. There was obviously nothing to find on examination, so most recommendations would suggest that this is a viral infection and doesn't need antibiotics. Both national and international treatment guidelines would not recommend the use of antibiotics for this case. So we were able, using the SP methodology, to also modify certain aspects of the SP roles to investigate our study objectives. So to look at the unnecessary antibiotic prescribing rates, we used the basic clinical case, but we were also interested in the impact of patient attitudes on getting antibiotics. So firstly, all our SPs were trained to never ask for antibiotics, but we also then sent a specific type of SP, what we called an informed SP, where they told the providers that they didn't want to get antibiotics unless it was absolutely necessary, signaling that they were not enthusiastic about getting antibiotics. In terms of financial incentives, we also manipulated certain aspects of the SPs. We sent SPs with and without health insurance. And in a more complicated study, we looked a little bit at an SP telling a dispensing GP that they would get any prescribed medicines themselves from a pharmacy rather than getting them from the doctor. That was intended to reduce the rationing incentive that might apply when dispensing doctors give drugs. So it took quite a long time to train a very intensive training program for our standardized patients. The basic training took about 10 days. And then we also had additional training for some of the additional roles. We had 20 SPs in total and for our study, and the training covered a number of aspects, including things like how to be a good SP. You obviously spent a lot of time on the clinical script and the presentation, but we also practiced the non-clinical aspects of being a patient, how to be a convincing sick patient, and we spent lots of time practicing the right amount of coughing that the SPs had to do for their to represent this bronchitis case. We also got the SPs to think about their personal circumstances and their backgrounds and try to standardize around their socioeconomic status, what type of jobs they might have, whether or not they were covered by health insurance, and their reason for visiting a specific provider on a specific time or day, just to be convincing when they presented to the providers. We also had to give them some training on different aspects of physical examinations they would expect, and how to avoid invasive procedures if providers wanted to do that. The training also covered aspects like remembering the consultation and how to use the software for data entry. And this was done through many practice consultations, both with the trainers and with real doctors. Just a brief comment on ethics. Our local ethics committee told us that we had to get provider consent for the SP study, which we did, but the providers were not told the exact details of the clinical case, which type of case we would be using, and the exact timing of the visits. And the consent was obtained a few months before we actually did the SP visits. But because of that, we had to use a method of checking that the validity of the SP method and that our SPs had not been identified, because that would compromise the methodology. So we did telephonic interviews once all the SP visits had been completed to check with the provider whether or not they thought any patients were suspicious or not real patients. In the basic study, we had zero detection rate. This table just summarizes the main outcomes that we were investigating in the study and the data collection tools that we used to get these outcomes. In terms of the technical quality of care or effort, obviously we're interested in whether or not the SP patient got an antibiotic, but we also used this checklist of the 18 essential items on history and examination and checked the performance of the providers against that. We looked at how long the consultation is, how many minutes they spent, and whether or not the SP was given the correct diagnosis. In terms of responsiveness, we looked at things like how long they had to wait, whether or not the provider gave them the diagnosis without prompting, and we also got our SPs to evaluate certain dimensions of the consultation on a scale. And lastly, we looked at costs and efficiency. And here we looked at things like the number of medicines dispensed or prescribed, the total cost of the medicines. And we were able to do that because we had a comprehensive database from South Africa of all the drugs registered and their prices. We looked at the percentage of generic drugs and also in terms of wastage, how many unnecessary drugs were given. In the last slide, I know this presentation is mostly focused on the methods, but just to briefly summarize the results from our study. Firstly, we found very high rates of unnecessary antibiotic prescribing in both the public and the private sector. It was 67% by private providers, and 78% of our SPs got antibiotics in the public sector. In terms of the checklist, the general quality of care was low in both the public and the private sector. Although it was slightly higher in the private sector in terms of quality and responsiveness, but they were much more wasteful of resources. And on average, the cost of drugs was 5 times in the private sector than it was in the public sector. In terms of our experiments, we did find that better informed patients could decrease unnecessary antibiotic prescribing. In the study, we were able to decrease the unnecessary antibiotics by about 15 percentage points in both the public and the private sector. But that means it didn't eliminate it completely. Over 50 to 60% of our patients got antibiotics, even though they said they didn't want them. And lastly, in terms of the financial incentives, we found that changing them did not influence unnecessary antibiotic prescribing, but it did affect other aspects of the consultation, for example, around the cost of medicines prescribed. Thank you. That's all from me. I'm going to hand over to Peter Migo to talk about his study in Kenya.
Thank you, Dwayne. I'm just putting up my slides now. Hello, everyone. My name is Peter Mugo, and I'm a research fellow at the Kenya Medical Research Institute in Nairobi. And I'm going to talk about the use of standardized patients in a study we've been doing on examining the implementation of HIV self-testing in private retail pharmacies. In the project, we use the term simulated clients because our clients or our cases are not necessarily patients. So HIV self-testing was launched in 2017, and this was among, in fact, the first form of policy that recognized the delivery of a public health intervention.
Peter, hi. Sorry, can you put the display on duplicate mode?
Oh, sorry.
Thank you.
Sure. Can you see them now? Can you see the slide now?
Not yet.
Oh.
Yeah, okay, go ahead.
Okay.
Go ahead, please.
Is that okay now?
Yes.
All right. Yeah, so the overall objective for the project was to get a better understanding of the policy environment in the pharmacy sector, to assess implementation of HIV testing as well as pre-exposure prophylaxis. You see the slides?
It's gone back to presenter view. Can you please change it to duplicate view?
Is that okay?
It's okay now, please go ahead.
Sorry about that. Okay, so we used or we're using a number of approaches to answer these project objectives, including a document review and in-depth interviews with policymakers to get a better understanding of the policy environment, questionnaire survey, simulated client survey, which I'm going to give more details about, and interviews with implementers. And finally, we are doing a research in synthesis and nominal group sessions to design implementation strategies. So coming specifically to the SP survey, we were able to issue of availability, so to check whether kits are available at pharmacies that reported that they're providing the service, to assess if the kit available are licensed, to assess cost, and finally to assess fidelity in terms of compliance with the guidelines that had been launched 3 years earlier. And with regards to fidelity, we focus mainly on privacy and confidentiality during provision of services, and the level of instructions, the counseling that is provided to clients. We did the study in 3 counties out of 7 counties of Kenya, which we selected because these are the counties that have a high HIV burden. They represent the 3 main regional settings of the country, and they have a high density of pharmacies, mainly because they are urban counties. And the population for the SP survey was about 100 pharmacies, 109 that participated in the questionnaire survey that preceded the SP survey. The pharmacies had to license the regulatory authority, and they had to have reported that they were providing HIV self-test kits. So our case was an adult client asking for HIV self-test that they can use to test themselves at home. And we had two variations. This would be an individual male or female or couple. And for the individual male or female, if they were asked why they wanted to test, we had them say that I think I could have been exposed. And for the couple, they would say, we would like to know our status before becoming intimate. All the cases were instructed to report that they never tested before for HIV. And this is because for someone who has never tested for HIV, there was an expectation that they would be given more comprehensive counseling and instructions. They were supposed to buy the kit that the pharmacy provider recommended, and they ask what to do if the result is positive, if the provider did not provide that information spontaneously. They also are supposed to ask if they could test within the pharmacy and whether the provider would see the results. This was to assess privacy. So we recruited SPs from the respective counties on a 1-month contract. This table shows some of the basic socioeconomics of the field workers. So we had 2 from Nairobi, 1 from Mombasa, and 2 from Kisumu. Our intention is to have a male and female from each county, but we were not able to get 1 from Mombasa because the one that recruited just dropped out a day before the training started. So the minimum requirement was a diploma, but we had 2 who actually had a Bachelor of Arts in Anthropology, and they also had to have some previous experience with research, though not necessarily with standardized patient methodology. So we did 1-week training and piloting centrally in Nairobi with 3 facilitators, including myself. On the first day, we had an overview of the study. We looked at research ethics, and including doing a course, an online course to get a certificate of research ethics. And also we used the SP method. And then on day 2, we discussed the draft script. We did role plays in the training room, and then we discussed the debrief questionnaire, which was a recap questionnaire done as smart. And then on day 3, we did dry runs at non-participating pharmacies. These were pharmacies that were included in the questionnaire survey, but that were not providing HIV self-testing, so they would be non-participating in the SP survey. And each simulated client did 1, and I also did 1 as a facilitator just to see how it was going. Then on day 4, we did the piloting pharmacies. HSC did 1 or 2 pharmacies. And then finally on day 5, we discussed the field logistics and the visit schedule. I think as Joanne has described, the schedule tends to become a bit complicated, but I think we're able to go through that quickly because we had the draft already in place. So the SP survey was conducted over a 2-week period in March this year. And as I mentioned, it's been done about 1 month before during the questionnaire survey. So I'll not go through all the numbers in the table below. I'll just focus on the red highlighted columns. So over the 2-week period, we did 102 visits, an average of 3.1 visits per day, which was similar across the SPs. And in terms of visit duration, so each visit took an average of 8 minutes. The SCs then took about a quarter of an hour to start doing the questionnaire. So very briefly on the findings. So in terms of availability, we found that 82% of pharmacies were providing the HIV self-test kits. 39 had at least 1 kit that was unlicensed. and the average cost was about $4. 60% of pharmacies had mentioned that testing was possible in the pharmacy, indicating they had a private space, and 27% of STs were told if what to do if the result is positive. This was spontaneously, but the proportion was higher when the SE prompted for what they should do. So initially we had planned for a number of variations, but we had to reduce these to 2 only. That's the individual and a couple, because none of the SPs could pass as an adolescent. And also we thought that, or we found during the pilots that the ever and never tested before cases would be too complicated. We also did not enact the in-pharmacy testing because we thought this would be too tricky, although some SPs had actually volunteered to do this. So the detection survey was also interrupted by COVID-19, but we are hoping that we'll be able to complete that, although it will be quite some time since the survey happened for most providers to remember. And on a positive note, the manual by Kwan and team was very helpful in planning the training and the fieldwork. So next, we'll engage stakeholders to develop a quality score, which should be sort of a primary outcome measure for the survey. And then we are also planning to use the ASC method to look at COVID-related services at the same pharmacies. We'll use the same field workers, but in this case, we'll have to do remote training and probably do call-in simulations rather than in-person visits because of the travel restrictions and the risk for infection. So I'll stop there and welcome questions and suggestions on how we can improve this, because we are still analyzing the data. Thank you. I'll hand over now to the next presenter.
Thank you. I will put down my slides and share this. Is my slides okay now? Okay. Good morning or afternoon or evening. First of all, I would like to express my big thanks for these symposium organizers to arrange this online virtual symposium and this skill building session organizers. Xiao Hui from School of Public Health, Nanjing University. My research focuses on health system research, evidence-based health policy and management, particularly on quality of care assessment and improvement. I'm now participating in a large study on the quality of primary care in several provinces of China using unannounced standardized patients. It's my honor to share our ongoing USP projects on behalf of our team. To address the session objectives, I would like to share the main steps of a pilot or feasibility study of the large project titled Assessing Quality of Primary Health Care in China with USP. I will go through the details while introduce our teams and working groups, followed by the objectives and the steps we conducted in a pilot study recently. At the end of this presentation, I will share the experience and lessons learned. A group of researchers gathered together back in 2017, leading by Professor Roman Xu. We created this primary healthcare quality cohort in China, short for Acacia Network. Standard patient and virtual patient methods are being employed to assess and improve quality of primary care and do research based on its data. Here is a project site. If you feel like, you can check it. Under the Acacia Network, 12 most commonly and frequently seen conditions in PHC settings in China have been developed based on clinical practice guidelines or evidence-based standards process of care and treatment plans. We will conduct the project in 7 provinces that can present a very broad socio-economic status of Chinese province, as shown on this map. A total of 1,200 PHC institutions were sampled. Among them, about 700 were public and 500 were private. The USPs will make about 2,200 visits to those clinicians. After the development of the cases, before the large-scale study, we conducted a pilot study to test, revise, and improve the SP scripts developed in the first stage to investigate the feasibility of the SP recruitment and training approach that is intended to be used in the full-scale survey and to assess the adequacy and the feasibility of data collection tools. We conducted this cross-sectional survey in 7 capital cities of the 7 provinces mentioned previously. The main steps can be described as recruitment, training, and field visit. Now I will introduce the steps, begin with recruitment. Our team designed and released the recruitment poster, which includes the project description, the timeline of our project, job description and requirements for both the SPs and the investigators, and the salaries and incentives for the participants. There's an QR code at the end of the poster for the readers to scan and register if he or she feel interested in. We released the recruitment advertisement through the most popular social media platform like WeChat and QQ. Referrals are also encouraged. Yeah, 2 weeks after the advertisement, student helpers helped us to call each of the applicants to confirm whether time slot is okay for them to participate all the training sessions and field visit. If the answer is positive, we invited them to the interview. And after the interview, we finalized the initial SP list who will be invited for the training. We can see from this table that at each stage of this, the set of SPs and investigators that is suitable for the study gets smaller. About 2/3 of the participants cannot come to the training and the field work for various reasons. Not available throughout the project schedule is a very important reason. As for the training part, a week before training for SPs, an online session was held for all the staffs and including the researchers and student helpers from 7 provinces. The training included project terminology introduction, the interview and the training, work arrangement, SP training highlights from pre-pilot and previous research. We also introduced the questionnaire to be used and the RedCap data collection and management tool and the finance and survey process, as well as documentation sharing among the collaboration groups are also discovered. After the interview, 110 SPs were invited from the 7 provinces to participate in a week-long training. The goal of the training is that the SPs and the investigators can ensure the standardization of the cases they play. The training includes the classroom instruction according to a standardized menu we developed, a dress rehearsal, and 2 field visits. Before the visit, we informed all the institutions and the physicians. The main aim was to ask the clinicians to offer advice on the script and the SP's performance for revise and improvement. 2 days later, we gathered all the staffs to summarize and discuss the issue identified from the training, where we got some quite useful feedbacks. We revised and updated the scripts according to the feedbacks from the visit. And after all the training sessions, the SPs and the investigators can finally go to the target institutions to do the survey. This slide presents the stage and the work we followed before, during, and after the visit. I listed here the responsibility of each team member. I will not go through the details. So far, we have finished over 700 visits in this pilot study. The reason why people quit after training during the field visit is mainly due to the SP's health condition and family issues. And we will take the advantage of time duration after the pilot study and before the full-scale study to conduct the second round of recruitment and offer online training for them. We will also offer intensive training for the SP recruitment recruited, but those who did not participate cannot participate all into the main study at this stage. And the experience is the pilot study is very important because it's necessary and useful in providing the groundwork. And in this study, we tested the acceptability and the revised script according to the real field work feedback. We also test the data collection and management instrument to ensure data we will collect during the large-scale survey was suitable and achievable. Secondly, we found that in this multi-center and multi-case project, the timely communication and feedback mechanism within project team are crucial to the quality control. So we developed a QN menu for the teams to respond to the SPs and the investigators quickly. And due to the funding limitation, we did not actually purchase drugs during the pilot. It prevented us from evaluating expenditure-related information, which is a crucial part. We have decided to purchase medicine prescribed by the physicians during the formal study. And to review and quick feedback is very important for the quality control. We have 12 cases in total and 7 provinces. So the communication and the management is a big challenge for us as well. I think that's all for my presentation, and it's a photo for our team. Thank you. I will hand it over to Wulan.
Thank you, Xiaohui. I just would like to share my screen first. Okay. Thanks everyone. Good morning, good afternoon, and good evening. And thank you for joining this skill building session. We've learned the experience from using SP from South Africa, Kenya, and China. Now we move to Indonesia, and I would like to share my experience on behalf of our research team. I would like to share our experience in using SP or standardized patient survey in Indonesia. First, I would like to introduce myself first. My name is Wulan. I'm a research fellow at the Kirby Institute, UNSW, Australia. And this is the title of my presentation.
Hi, Wulan. Are you sharing your screen? Oh, yeah. Okay, great.
Yeah. Okay. Yeah. And this is the outline of the presentation. So I would like to talk briefly about the Indonesian context, and then move to the Pintar study where the SP survey was conducted, and then moved to talk about our SP survey, and then talk about critical steps in designing and implementing SP survey or standardized patient survey. So Indonesia is the largest archipelago in the world. It has around more than 17,000 islands. 6,000 of them are inhabited. And it's the 4th most populous countries in the world, with 270 million people living in the country. About health services, like many other countries.
Sorry to interrupt you. I don't think we're able to see your slides.
Okay. Okay. I can see my slide now. Should I just maybe stop sharing first and then go back again?
If you could reshare, or I can also try sharing your slides if you prefer. We can see if that works too.
Okay, hang on. Maybe I can try it first and see if. Can you see it now?
No, I cannot.
Okay, maybe you can help me.
Okay.
Can you help me with that? Sorry. maybe I can stop screen.
I have it pulled up here, so let me just try to share.
Hello, Ada.
Hi, everyone. I am not share your screen yet.
Okay.
Have you stopped sharing your screen?
Sorry.
No worries. Sorry about the technical difficulties, everybody.
Okay, maybe we can move to the next presenter first, and then I will sign out and go back signing in.
Okay, sounds
Sorry for
good.
this.
So I will do the next presentation. Let me just get my slides up. Okay.
Well, we can still, it appears to still be, okay. Nope, I think we're okay. Yep, perfect. Thanks, Ada. Thanks, Juan. Ada, you're on mute.
Thanks. Okay, so I'll be presenting lessons from the Katub project in India. And this is a standardized patient study with quite complex collaboration. And so Katub is shorthand for the quality of tuberculosis care. And the goal of the Katub project, which was implemented in 2014 and is still ongoing, is to conduct a quality of care surveillance with the standardized patient method. And so we were measuring quality of care in the context of scaling up, in the context of 2 TB provider networks programs that were being scaled up in 2 Indian cities. And so I will present 5 lessons from this project that I hope will help you if you find yourself implementing the SPs in a complex collaboration. I'm the project director for this project, and what I present today draws on work I've done with Dr. Madhukar Pai, the PI, one of the PIs of the project at McGill University, Jishnu Das, who you'll hear from later in this session, who's the other PI of this project at Georgetown University, and then Benjamin Daniels and several other researchers from various institutions. You see here. Okay, so just to set a bit of context for this project, we're examining tuberculosis. Each year, there's 10.4 million TB cases and 3 million missing TB cases in India, and this accounts for a portion of the large portion of the global TB burden. The government of India has made very ambitious commitments with respect to tuberculosis. This includes universal access to quality TB care for all the patients in the community. And the government also aims to eradicate TB by 2025. These commitments are very challenging and immensely complicated to achieve because for many reasons, one of them being that there's a very vast and variegated private sector that dominates healthcare seeking in India. And you can see listed here a sample of the various training and degree names that providers have. And also on the patient side, it's quite complicated. This diagram shows pathways of patients, and you can see that the pathways to get the right care are long and convoluted. The study here found that an average TB patient is diagnosed after a delay of 2 months and is seen by 3 healthcare providers before diagnosis. And so you can see how these issues could lead to individual and public health consequences, but at the same time, improving TB care and eradicating TB are quite complex questions. So in an effort to improve this situation, in 2013, the Gates Foundation funded 2 NGOs to implement a private provider network in Mumbai and Patna, India. And these are 2 cities with a combined population of 12 million, or 17 million, sorry. And our team was tasked to conduct a quality of care surveillance. And we were with the SP method. And we're one team of 5 research teams working to inform the scale up and operations of these provider networks. So from 2013 into 2014, we began to assess the on-ground feasibility of using the SP method for program improvements in TB care. In so doing, our team designed 4 SP case scenarios reflecting certain moments patients may find themselves in while seeking care for TB. But at that time, no one had used the SP method for tuberculosis before, and we didn't know whether it would work methodologically and on the ground. So before we could conduct quality of care surveillance in these 2 cities, we had to validate the use of the method for the tuberculosis case scenarios we designed. And in this process, we wanted to make sure providers didn't pick up on the fact that actors were presenting these cases. And we needed to make sure we could conduct the fieldwork ethically based on human subjects research regulations before moving forward. So making sure that there was minimal harm to any participants, not only the SPs and the providers, but also real patients that would be visiting these clinics. We ended up validating the approach and we proceeded with our project. And the programs, in 2014, the programs, the implementation teams pushed forward with citywide mapping of providers. I'll get back to the importance of this in a moment. And since then, our team has been circulating SPs in both cities with specific sampling techniques. And meanwhile, the NGOs initiated, scaled up the program, which I'll call the PPIA program. And ultimately in 2018, the programs were transitioned to the city governments. And so you can kind of see how in this context where a large program is being scaled up from scratch, can use methods like SPs to understand whether or not quality of care is being improved. And so we conducted the Katub project ended up being a massive standardized patient study, and we conducted the largest SP study ever conducted to our knowledge with over 11,000 SP interactions. So that's one SP visit to a health facility or provider in the Indian private health sector. And so these interactions were conducted in 3 rounds, and we were able to impose a representative sampling design with the mapping data from our partnerships. This allowed us to make comparisons across provider types and as well as providers who are in and out of the program network over time, similar to a cohort study over 6 years. And today I'll show you some lessons we learned in this process. Here are the 4 SP cases for tuberculosis we developed. We start with a typical TB suspect textbook case, and then we also have a MDR suspect case. Our team recruited and trained SPs to portray these, and they visited sampled providers. Those of us on the research team who led the sampling worked very closely with the field team to make sure detection risks were minimized as much as possible in the field, so that as more and more SPs visited the same doctors in our sampling frame, that they wouldn't be able to detect them. And so moving on to what did we learn? So the first lesson was that upfront investments in agile communication and data production are critical for saving time downstream. This applies to a lot of projects, and in my experience, it applies even more to SP projects, and especially ones with complex collaborations. Here you can just see the various types of meetings and frequency of meetings and documents and collaborative documents, closed door discussions, and so on and so forth that really helped us create and reinforce communication channels. This process helped us immensely in building trust with our partners and within our team, not to mention in understanding what research and program questions could be answered with SP data and what challenges we would experience in achieving those. This involved many partners. As you can see on this left side, this is our team, and we're 10 researchers, and then our field team as well. And we're one of 5 research teams. We have the program implementers, the funders, other consulting and data agencies, and the state and citywide governments who are pushing forward this larger program. The second lesson that we learned was that partner organizations understand and use data very differently from research teams. For them, what is merely information today doesn't necessarily systematize into data that can be efficient and used for other purposes, such as research. And so, but there were many opportunities to work together to ensure program data could be used for research. And some of these efforts to improve this did and did not change the way data was used or information was used. So the third lesson that we learned from the KTUB project is that sequencing activities, so sequencing activities of SP fieldwork on the learning curve and staying agile for the unpredicted stuff pays off. This is true for any SP study, and especially for long and complex ones. Operation challenges compound over the number of teams that are involved, and it's really good to prioritize what's important now and what can be dealt with later, and understanding anything can change at any time is a daily exercise, and just keep iterating on that. Here I show one example of this. Again, our study was implemented in 2 different cities here, Patna and Mumbai. In each city, we had a team of about 12 to 17 SPs. Each did about 0 to 3 and almost never more than 4 interactions per day. This was a nice number for our supervisor team to manage. And we visited the idea of ongoing SP visits in both cities simultaneously for our surveillance project. But ultimately, we decided to sequence and alternate the fieldwork, starting with Patna. This was because Patna had a simpler, in contrast to Mumbai, layers of the private sector. And then within the city, we sequenced data collection to also move from most simple to most complicated. In Patna, we moved from chemists who have more standard operating hours, from like 10 a.m. to 10 p.m. So visits were very easy to conduct. And then we moved on to informal providers who were less available, and then formal providers who were the hardest to track down. And this offered us an opportunity to learn the dynamics in each city, and for our field team to also learn the logistics and optimize it as interactions became harder and harder to conduct. We also based this decision on our previous data that we didn't expect our main outcomes from the program to change in the time it would take us to return for another round of data collection. Sorry?
1 minute.
Okay, thanks. Let me go up a little bit faster through these, but another example of sequencing activities is where we could compare walk-in visits, where a SP would just walk in and do what the provider or the receptionist would say, and we would compare that to an SP having a targeted appointment with a specific provider. And also doing things in sequence helped us identify unknown pills that came from these interactions. The fourth lesson was that validating the SP method for one health condition scaled quickly. It turned into adaptations in China, Kenya, South Africa, and Nigeria, and we're able to do cross-country analyses, which couldn't be possible without standardized cases and instruments. And we also gathered a lot of data on how providers do not manage TB well. We also produced these resources, some earlier today, and then we also have these this resource manual on how to conduct standardized patients to measure healthcare quality for the field teams and researchers. And the last lesson I'll close with is one can't pull these studies off without a truly multidisciplinary team. And our team, we're lucky to have economists and epidemiologists and clinicians and anthropologists on our team, and everyone pushed themselves on how to add value to a collective, but the sheer complexity of the environment and the programs really emerged from mixed methods. And the same questions that we would ask were transformed according to disciplines. And this helped us understand what was actually happening. And one question particularly was whether doctors were really the center of the program, or was it human resources, for example. And I'll just close there and give my acknowledgements to the many people on this team. Thank you.
Thanks, Ada. I think we're now going to turn back to Wulan, who's going to try and share her slides again.
Okay, I'll try this time. Hopefully it works. Okay, can you see my screen now?
No.
Ada, I think I need your help to help me with the...
Yeah, let me put up the...
Well, it's Virginia here, just to say we might need to perhaps move quickly through some of the background because we're just getting a little behind time. Not that it's your fault, but thank you.
Yeah. Sure. I see the message that you started to share your screen, but it doesn't come up in my monitor.
Okay, well, I'll tell you, you're on the very first slide.
Okay, yeah, I can see it now.
Okay.
Thanks, Ada. Maybe I just need to skip this. So next slide, please. Next slide. Next slide. Next slide. Yeah, so this is, I'm going to share with you our experience of conducting SP survey in our PINTAR study. PINTAR study stands for Protecting Indonesia from the Threat of Antimicrobial Resistance. So just a bit of background around antimicrobial resistance in Indonesia. While there are no formal estimation of AMR or antimicrobial resistant burden in the country, however, AMR is estimated to be increasingly prevalent in the country. And despite the current effort to develop a national surveillance system, the current data has been sporadic and often only from few hospital laboratories. And inappropriate use of antibiotics at the community setting, particularly from private drug sellers, is thought to be one of the drivers of AMR in the country. Next slide, please. Next slide. In terms of private drug sellers, where the PINTAR study is conducted, there are a large number of these facilities in the country, and a report has mentioned that around 93% of clients are reported to obtain their antibiotics from these private drug sellers. Next slide. So this is our PINTAR study. As I mentioned earlier, it stands for Protecting Indonesia from the Threat of Antimicrobial Resistance. This study was conducted with lead of Professor Virginia Wiseman, with collaboration with several institutions in Indonesia, UK, and Australia. And I think I need to mention here in Indonesia, we have There's three institutions involved: the Universitas 11 Maret, led by Professor Ari Probandari, Universitas Gajah Mada, led by Professor Sri Wibawa, and the Ministry of Health, led by Dr. Hari Paraton. If you would like to know more about the Pintar study, you can visit our website at www.pintarstudy.org. Next slide. The overall aim of the Pintar study is to improve the dispensing of antibiotic by private drug sellers in Indonesia to address the health security threat of antimicrobial resistance. But we have several specific aims in there. One of the most relevant to the current topic is the second objective, which is to determine the proportion of consumer visit to private drug sellers for common clinical condition in which antibiotics are dispensed without a prescription. So I think this study is quite similar with the study presented by Dwayne from in South Africa. Next slide. Pintar study is conducted in 4 phases, and now we are in the third phases. And the SP survey is used in the phase 1 and phase 3. The phase 1 is situational analysis, while the phase 3, we implement intervention and then we evaluate our intervention using the SP survey. Next slide. In the phase 1, we use mixed method study to gather baseline information on antibiotic dispensing without prescription by pharmacies and drugstores, and also explore factors associated with this behavior. In this study, we use one SP survey, and the second one is qualitative interview with PDS, or private drug seller staff and clients. Next slide. The SP method was used mainly to reduce Holton effect, like Jessica mentioned, and also because we need to standardize the patient characteristic because we understand that the behavior of health providers sometimes is influenced by the characteristic of the patient, so we would like to standardize that. And in this study, SP visited private drug sellers and portraying symptoms associated with 3 conditions commonly or prevalent in Indonesia, which is child diarrhea, suspected tuberculosis, and upper respiratory tract infection. Next slide. In each SP cases, this is the enacted scenario that SP need to portray during their visit to pharmacies and drugstores. For child diarrhea, SP need to mention that they need a medicine or for his or her niece, which had been having a diarrhea for several days, and the diarrhea is watery without blood and mucus. For tuberculosis cases, the SP need to mention that he had a deep yellowish green sputum producing cough for more than 4 weeks. For upper respiratory tract infection, the SP need to mention that they have flu-like symptoms with fever, runny nose, and sore throat. And then the SP, after complaining or mentioning the symptoms to PDS staff, the SP need to ask for medicine. If the PDS staff didn't give them antibiotic, then the SP need to ask for one. Next slide. So the team involved in this SP survey, there are lots of team members. We have facilitators for SP training. So we conducted SP training before the data collection. We also have a local trainer. We have project manager and district coordinators, and all nine SPs in each district. The facilitators for the SP training consisted of the investigator team and local trainers. We developed training manuals, SP checklists, safety procedures manuals, set up data collection instrument, and establish connection to the server. And also we developed a standard operating procedures for project manager, district coordinators, and SP. liaised with the institutions at the district to help with the SP training and also conducted the SP training. Next slide.
1 minute.
Sorry, so just a brief about the steps. So in designing SP checklist, there are several steps that we have conducted in the SP survey. The first one is in designing the SP checklist. SP checklist is a kind of structural questionnaire that SP need to fill out after the interaction with PDS staff. And it should be, during the development, we have to look at the national or international guidelines or previous SP studies just to allow us for comparison. And for recruiting SP, we need to consider several relevant characteristics like ability to memorize the interaction and also the acting skills. We also need to consider the gender and age of the SP, because other studies mention that this also have influence the providers' behaviors. And in choosing data collection tools, we need to use things that is easy to use and practical, and also safe, and also easy to implement where when network or internet connection is not available. And we also need to develop SP manuals and safety procedures. Like we need to anticipate if for the detection during the field visit. And we also need to mapping the facilities where the SP need to visit. Firstly, we need to use the master list from the health authorities. In this case, we use the list from the district health office. But it turns out that some facilities has been closed down like permanently, and some of the facilities need changing their address. So we need to consider that when we implement SP survey. And also for conducting SP survey, we need to consider the background of the trainees or the trainers themselves. We need to recruit SP and the trainers who are able to speak local languages, because sometimes the interaction with providers is also involve local language. In the SP survey implementation, make sure the data is always being saved in the server each day, just to anticipate that things happen unexpectedly. And the during SP evaluation, we need to analyze the data as soon as possible, and if it is also useful to use other methods, like in this case, in our study, we use qualitative study to complement the results of the SP survey.
Thanks, Wulan. Sorry to interrupt. Because of some of the issues we've had with the slides, we might actually have to wrap this session up so we have time for Q&A. I'm very sorry that you've been cut off, but people will receive all the slides. And they'll have our details as well if any of the participants would like to follow up further with you. I think you've given a really nice summary of some very practical issues. Is there any final comments you wanted to make, or are you happy for us to continue?
Yeah, I'm happy to continue.
Thanks for your question. Thank you. Okay, so if we now move on to the Q&A, I'd also just like to ask you if we could run into the break a little bit, because of the issues we've experienced, where we are running a little behind time, so we might not get a full 15 minutes for the stretch break. So let's move on to the questions, and we've had some fantastic questions asked, just brilliant. So the first question I'd like to ask is to Jess. Could you please elaborate on the ethical issues in using mystery patients in research? I know that you've already touched on this, but could you maybe just highlight what you think are some of the key things there, Jess?
Oh, hi, thanks, Virg. It's a really interesting question, and I was only able to talk briefly. I think the main concern is that, especially from a medical research perspective, a kind of norm of ethical research is that your participants have fully informed consent. And so when we think about standardized patients from a provider perspective, they are by definition not fully informed. And I very briefly showed some of the options for the types of consent that you can ask for from providers. And so one of the options is to ask providers for consent, and they are fully informed about what the process is for the standardized patients. They understand the idea behind the standardized patients, the sort of data that will be collected, and the use of the data, but they still don't know the exact case. But we also do use this option of, or some studies have used an option of a waiver of consent, which is where the providers aren't asked for their consent in advance, although in most of these studies they are informed after the study's been completed that it's taken place. And it is quite a controversial issue, the question of whether it's fair to providers to send these mystery shoppers to measure their quality of care without asking them. But then there's a very strong argument, I think, that the quality and safety and care is really important for the general public, and so it's not unfair to measure it, and that you can't really measure it as well if you ask for consent in advance. So I think it's a sort of open point of discussion about the whether it's ethical to do these studies with a waiver of consent, or whether you must always ask providers in advance for their consent.
Great, thanks a lot, Jess. It's a tough one to summarize and in just a minute or two, but that was very helpful. Thank you. So over to Dwayne now. We've got a question: what makes a good SP data collector? And what sort of training do they require? And then also, what happens if a person is detected and they while they're performing a clinical case? Over to you, Dwayne.
Hi, yes, thank you. I think a number of different SP studies have used quite different people as SPs. Some have used actors, that was one of the questions. Some have used trained field workers, some have used very educated people, some have used just people from the local community. So it depends a little bit on the study objectives, because you may want to, for example, have people that are not going to be easily detected. They have to speak the local language. They have to look like the person who would normally attend that facility. But I think it is important to recognize that actually this is quite a complicated data collection task. It's not what normal field workers do. They have to act a case, they have to memorize the script, they have to be able to remember the consultations and use the software or whatever device you're using to record the data. So it's quite a complicated technical exercise. And I think that's why we all spend so much time on the training part, because all of those aspects are things that you can train people to do with practice. And I think that's generally what we found. I mean, we've tended to use fairly well-educated fieldwork, people with experience in collecting fieldwork, and then add to that the aspects of being an SP. So we've tended to use experienced researchers or people with experience of research rather than actors in our experience. But I think people have used all sorts of different things. Some people have used actual patients. Sometimes you need to be, I think there was also a comment about mimicking physical examination signs, and that is difficult. It's possible to do for some things, but it's not possible to do for everything. And so some studies have used actual patients, although that raises other ethical issues also in relation to that. I mean, in general, what we have done is we've trained more people than we need, and then we select the best of them, because just some field workers do well and some field workers just are never really able to grasp the methodology. So I think it's useful to train more than you need and then choose the best of what you have. I think we've spoken about the consent procedure, and I think one element that's important in terms of detection of SPs is that providers might be wrong. So they may think that a patient that's coming to see them is not a real patient, and in fact they are. So something might alert them to being suspicious. But people go to providers for all sorts of reasons, and sometimes that is quite suspicious. They want a sick note for work or something, so they don't seem very convincing. And they may not be your SP; they may just be some other patient. So in the consent procedure, we are quite strong at enforcing that if the provider thinks that this patient in front of them is not a real patient, they shouldn't change their behavior in any way because they might be wrong. So they need to continue as normal and then inform us immediately that they think that they've had a suspicious patient. But because they might not be a real SP, they need to treat the patient normally. Well, we have had cases where the provider actually did confront the SP, and that sometimes does happen. I think in all these cases, SPs are trained to try and maintain the idea of being of a real patient as long as possible, but they also train that if that is no longer possible, in other words, the provider confronts them, or for something happens like they're being forced with an injection or given some drugs, then they may have to reveal that they're an SP, and then of course you lose that data point from your study. But it does happen, and SPs have to be able to drop that acting role at some point if necessary in the study.
Thanks, Dwayne. Training seems to be just the critical, part of the SP study, perhaps more so than many other types of studies that we conduct. A question over for Xiaowei. How can we consider SP studies for family planning patients, as they're often reluctant to answer questions related to quality of care? Have you had any experience in that area, Xiaowei, or any views on that? You're on mute. You're still on mute. Xiaowei?
Sorry, I was muted. Yeah. Thank you, Virginia, for this question. I think they might be a little bit confused about the SP method itself. Normally, in our study, we are not interview the patient or the family members. Instead, we will send the train and send the SPs to the clinic or the institutions. And the SPs will play a member of the family to seek care or play themselves to seek care for providers about the family planning service. So the question itself, they asked if the SP reluctant to answer questions may not be an issue, as conventionally, as the conversation will not happen. I think, yeah, it's regarding the SP method itself. And the SP will reply the doctors or have been peer, or I think, yeah, this question is a little bit confused. Yeah. And in our project in China, we did not actually cover the SP cases regarding the family plan.
Okay, thank you. Thank you. I think just on that, I suggest people look at the paper Jess referred to. In that paper, they provide references for studies across a whole range of settings and services. So you can probably get a nice picture of where the SP method's being used. I'm just going to switch now quickly to Wulan. There's a question that I know that I think you will have something to say. With COVID, do you see the possibility of conducting SP virtually in digital health context, and what impact has COVID had? Great question, thank you.
Yeah, thank you, Virginia. Thanks also for the question. This is interesting question. Yeah, I think in the current context where almost every country have the crisis due to pandemic, I think there is some risk if we send people to go to the health facilities. With regards to having an SP survey using a digital tools? Is that the question? So I think it depends on the SP cases or the cases that we are going to portray. If the SP in our study only needs to complaining about the disease symptoms and asking for medicine, I think they can do that through a telephone or any digital tools. In fact, it is the current practice now, especially in Australia, when people get sick, they are not allowed to go to the facilities right away. They have to make a contact with that doctor to telephone and to tell their symptoms, and then if the doctor allows them to go to the facilities, they can then go there. So if the SP only involving an action where SP only complaining about the symptom and asking for antibiotics, I think that's feasible. But if the cases also involves where the providers need to provide a physical examination, I think that would be a bit complicated. I think that's we need to consider using the SP in that context.
Okay, great. Thanks, Willa. 3 very quick questions. I think these are really important ones I'd hate to see us miss. Ada, does the SP method, is it more suitable for measuring quality of care for a one-off condition or for a new patient?
So if I'm understanding the question correctly, I'm kind of thinking of like whether or not we can use standardized patients as in a one-time visit with a provider, or if the provider can, or if the SP would return and do follow-up visits. Is that also how you understand it?
Yes, I think that example was chronic illnesses that may require multiple visits versus the one-off. Yes.
Yeah, so in my personal experience, I've not done standardized patients for chronic conditions. I think Xiaohui and then later on Roman will talk about the use of virtual standardized patients to understand quality of care. But we did a small pilot in Delhi where we did have our TB, our first standardized patient case did visit as the textbook case and then followed up after several visits. And it's very logistically complicated to do and like to code up how the providers interact with the follow-up visits, because each provider has his own or her own algorithm in their mind. And so we only did like 10 of these that followed 10 SPs who followed up in care. And it was actually quite complex to code up and to understand what was going on. I think this might be something that needs to be looked at more if it wants to be used more, given that that is kind of one of the current limitations, maybe that might not be in the future of standardized patients, in that it's very hard to understand chronic care or other conditions that need follow-up visits, or in a similar vein, visits with providers where they're very familiar with their patients. Yeah.
Great.
I don't know if
Thank you.
comments on that as well. But.
Would anyone else like to briefly comment on that? We have two remaining burning questions we'd like to raise with you. Let's move on then, that's all right. Jess, there's been a question about evaluating the process of care. It's a little bit related to one of the previous questions. Starting with an appointment setting, waiting time, provider-patient interaction, then continuity of care. So it does relate to Ada's point. How do you think we're going on that front with SP surveys?
It's a really interesting one, because Yeah, it's hard to say whether SPs are necessarily the best tool for measuring something like that, especially experience of care, because I think that where SP's real strength are is to get an objective measure of quality to say this happened or this didn't happen. I think appointment setting is something that has long been done by SPs or kind of just phone surveys, because it's quite easy to do in that way. But things like the experience of care and whether the patient feels that they were treated well, one could still argue is better measured by something like an exit interview. But more objective measures like waiting time, I think are a great thing to measure with a standardized patient, because they're going in remembering that they're measuring it compared to an exit interview with a real patient. So I think they're complementary tools. And certainly I think a lot of people here will have also used exit interviews in their studies to measure different things. And in our study in Tanzania, we also did exit interviews with real patients because they provide a kind of another dimension.
Great. Thanks, Jess. Peter, I wanted to wrap things up with you if I could. There are a couple of questions around costs. I think it's a really important issue because it's often flagged as a fairly resource-intensive activity. Could you just very briefly, before we take a short stretch break, to share some thoughts on costs?
Sure. So in our study, it was a bit easier because we were dealing with a limited number of services. That is basically the SP would present and ask to buy a test kit, and they would buy the one that the provider recommends. So the costs that are presented are for the kits that the SC is bought, and we think there are some reasons why the provider would recommend one test kit and not another, because we also ask them to, before buying the kit, to also ask what kits are available. So we also have a list of kits that are available, but we collected only the cost of the actual kit that they bought. So they actually bought the kit, and that is the price that we are presenting there. So I guess for us it was a bit easier compared to, for example, trying to monitor cost of let's say consultation and lab tests and so on.
And Peter, sorry, just in terms of doing the survey from the research side of things, was that a costly type of survey for you to conduct?
No, not. I mean, compared to other studies that I've read about, I would say it was relatively less costly because, for example, we only engaged the SCs for a month, and there were only 6, and the visit durations were quite short, so we were able to do like 3 visits per SC per day. The only cost, I think, the main cost was actually buying the test kits and the travel to the various pharmacies.
Thank you, Peter. Anyone else like to just make a final comment about cost of running a survey? Any reflections on that?
I think there were a number of questions about how much you pay SPs, and I think in general it's it's similar to other field workers. That if you're doing hired people to do exit interviews or observations, so I mean in general you're paying sort of experienced field workers, and so we normally pay SPs at the field worker rate. There are other costs. So for example, we did work in the private sector, and then you have to pay all the fees and things. So they can be an expensive methodology depending on your application.
Dwayne, from an efficiency point of view, there are also questions about whether the same SP can, or multiple SPs can visit the same facility or outlet or
I think that depends a little bit on the setting. So when you have a lone private GP, you can't really send the exact same individual back to that GP unless, because they will recognize them and they will know that it's a repeat visit. So as an independent data point, that's not possible. In the public sector, where there's a range of providers, you might send a number of SPs and they may not see exactly the same provider. But I think in general, we avoided sending an individual SP back to the same public or private provider because they would they might see the exact same person, and that would be a problem. So that's one of the reasons why we used a range of SPs, so that we could avoid duplicate visits.
Great, thank you, Dwayne. Thank you so much to all of the participants in this session. It's been great. Unfortunately, we've always can't answer all the questions, but I think we've had a good stab at it. We've eaten into our stretch break, unfortunately. I think that maybe we'll give everyone 2 minutes, if that's all right, and then we'll reconvene in about 2 minutes' time. That might just be enough to run to the bathroom or get yourself a drink. Thank you. Thanks, everybody.
Thank you.
Okay. I'd like to welcome everybody back now. And apologies again for a very quick stretch break. We're now going into our panel session. And we have Professor Cara Hansen from London School of Hygiene and Tropical Medicine, who's going to manage the panel session for us now. Over to you, Cara.
Super, thank you very much, Virginia, and thank you to all the speakers from those first sessions. That was just fascinating. So now we've got 3 people who have experience in doing SP studies in different parts of the world. We have Mylène Lagarde from LSE, Roman Shu from Southern Medical University in China, and Jishnu Das from Georgetown University in the US. And we are going to ask them to each start by reflecting briefly on their top tips, the things that they have learned from doing these studies, but also to reflect on what they think is potentially a gap, something that where more work is needed and where we would all benefit from additional experience and evidence. So I'm going to ask them to be quick because there are still some unanswered questions and there's still a chance to keep asking questions of these panelists. So I think I'll start with you, Mylène. Do you want to begin by telling us your top tips from the things you've learned from experience?
Yes, absolutely. Thank you very much, and good morning, good everyone. Good evening to everyone. So I've done standardized patient studies in a few settings in South Africa, as mentioned by Dwayne, but also in rural settings in Senegal and in Tunisia in the private and public sector. And I would say that I have 2, I mean, in addition, obviously, to the number of very, very good points that have been made by the previous speakers, I have 2 tips that have stayed with me as very important. The first one is, I think that the crucial need to understand precisely the setting in which you're doing these standardized patient studies. And I know that might sound a bit obvious, and to some extent we all think we know very well the settings in which we're doing research, but actually I think there is a clear difference in terms of the amount of details that are needed to undertake a standardized patient study. And I think Jess is the one who started by saying that, understanding, for example, the pathway, the route of the patient. And this requires not only some observations in a few facilities, but some extensive piloting in our experience, and also, as Ada was mentioning, the ability to have a responsive and agile data collection system and a great communication within the team, so that you can adapt as you go to circumstances you had not anticipated before. So the first important thing is to try and anticipate as much as possible. So for example, when we conducted our studies in South Africa, we were told that in the public sector they had introduced an information system whereby they were able to detect when patients were shopping in different and were doing facilities in different public health facilities, which was exactly what we were intending to do. So we had to work with the public health authorities to try and set up a system whereby the visits of our standardized patients would be deleted from the system every evening, for example. So you can imagine that requires quite a lot of work and anticipation in advance. You also need to understand the pathway of patients in order to train to develop good tools and train your patients effectively. And the second important lesson that we've learned is the need, obviously, to build consensus when defining appropriate care and correct patient management, but also the challenges in doing that. So it's required and it's needed if you want to be able to, if you want your research to be shared and used by policymakers and key stakeholders. They have to agree with the standards and the measures by which you are evaluating quality of care. But it also raises all sorts of challenges in terms of, so who should be on a panel or involved in discussions to set, for example, to define what are the recommended standards or what is the appropriate care. So you should, for example, have a mix of practitioners and experts. I mean, I'm already over my allotted time, so I'm going to stop there, but I can come back to that a bit later.
Thanks very much, Mylène. So know your setting and think about who should be helping to set the standards for assessing quality of care against standards. Roman, can you go next? I have to say the scale of the study that you have been doing with your collaborators in China is many-fold bigger than some of the other studies around. So I might ask you to come back to that a bit later on, but for now, can you tell us your top tips and maybe something about where there's a gap?
Thank you, Carol. This is very exciting to join this discussion. As Carol said, we have been, for the past couple of years, planning and piloting a fairly big, complicated, standardized patient to assess quality of care. And we have an intention to make it a cohort study as well. So for every 5 years, we come back to the same facilities and providers and measure them. For the top 2 tips we are going to give, one thing is please do document many of the things along the way of doing USP. Because in our experience, when we are trying to learn from our previous studies, we found many things we are looking for are not well reported in the published literature. So we are thinking maybe we should come up with a common understanding and a consensus on what is the reporting guideline for studies using standardized patients, as there are many reporting guidelines for clinical studies. So people, for yourself and also for the other people trying to learn from the experiences, they have the necessary tools. For instance, we are very interested in knowing how people deal with some of the cover-up of symptoms and the signs. For common colds, how a healthy person play the sore throat, how when people have a fever, how do they but they are the healthy person do not yet have a fever. How do you deal with those situations? At that time, when we are designing our scripts and cases, we are looking at those issues, but they are not very clearly explained in the previous studies. And the second tip we would like to give is really be very creative, because lots of the challenges of using standardized patients can be dealt with a lot of creativity. For instance, we are doing the nationwide study. China has, wow, I don't know how many dialects. It's impossible for us to train a local player for each of the locality, and that's financially impossible. But how can you justify a person who are not speaking the local language in the village clinic where doctors tend to know everybody, and how to justify that? So we thought, well, those will be people who may be the company representative for the fertilizer, and they are outsiders but stationed in those areas and looking forward to providing technical support for fertilizer companies. So they happen to be sick in your area and come to seek care. We also have students posing as doing some summer projects in the area and got sick, etc. A common question is how do you deal with many conditions where people need test results, lab test results for diabetes? If there's no lab test results, the physicians will simply stop the consultation and insist they have a lab results. So how do we deal with those situations? But we came up with some interesting solutions. I have no time to explain all the details, but one thing we want to emphasize is with creativity, you can come up with a lot of solutions to many of them mission impossible. Thank you.
Thanks, Roman. And I think that combination of being creative and then sharing your creativity through really rich descriptions of the methods. And so many journals now allow you to have large online appendices, and that's a great way of sharing the detail of studies that won't necessarily be able to appear in the main paper. Jishnu, I'm going to turn over to you now. Top tips and potentially an area for further work. Over to you.
Sure. Thanks, Kara. And also talking about past work and online appendices. We have a paper, Ada Kwan is a co-author and one of the first authors in BMJ Global Health that comes with a 150-page online appendix. Hopefully that's useful for people. It has a lot of material on ranging from consent to how to develop a patient. I just want to talk about one thing which, since we started this in 2008, this has come up again and again, which is for us, the major difference between a survey, whether it's an exit survey or vignettes or a facility survey and standardized patients, is in any survey, you really want the surveyor to follow a protocol. With a standardized patient, you want them to react to situations, many of which will not be anticipated, in a way that doesn't destroy the case, right? So to just give you, what I find to be the most fascinating part of the development of the standardized patient is they have to go in with a story that makes sense, right? Not only about why they're there, but what their life is like, right? Because any part of their life might come up for legitimate questioning during the interaction. At the same time, that story needs to be consistent with the biomedical aspects of the case they're presenting. So for instance, so let me give you two specific examples. We started a case where there's a child who has diarrhea, but because you can't, for ethical reasons and for obvious reasons, you don't want to use a child as a standardized patient. We have a parent who goes to the doctor without the child. It's very important, for instance, to know that, or to convey to the doctor that if this is a viral diarrhea case, you don't want to lead the doctor astray towards a bacterial infection, but most poor people have poor access to water. So the standardized patient needs to internalize that they have been breastfeeding the child, right? So that you don't get this kind of possibility of infection. But then you have a problem, because why is the mother who's going to the doctor out of the house if she's breastfeeding her child? So it's very interesting. When we did this in Nairobi, patients were, the standardized patients with whom we always developed the script jointly were very clear that it happens all the time because the traffic can get really bad on moment's notice, right? And they said it happens all the time that they're out, they thought they would make it back home in 20 minutes or 45 minutes or whatever it was, but the traffic got really bad and it was taking them 3 hours, right? And that's, so very importantly in these cases, it's that the biomedical aspect of the case has to give, and the life of the patient has to always lead the doctor towards the inference, towards a certain inference that is not complicated or confused by answers or questions that may not have been anticipated or that may not have been thought about. So I'll give you one last example and stop there. We have some work looking at whether men and women are treated differently for tuberculosis. And again, when people think of standardized patients, they think that the case is standardized, which is of course right. But imagine that you want to give to the doctor the impression that this is an average person from the population, right? If in India, it's a man and the doctor asks, well, what do you do after you get back home from work? And he says, well, I go out and hang out with some friends, and maybe I go and drink a couple of teas or go and see a movie. That's totally fine. That is an average male. But if a woman goes to a doctor and is asked, what do you do after you come back home from work? And she says, well, I go out and hang out with my friends, and then I go out to the movies. That is not an average woman, right? So if you want the doctor to infer that these are average draws, these patients are average draws from the population, you have to be careful that you're giving them information that may be different, but that leads towards that inference. So for a woman, an average woman, in our case, it's about 25. If she actually comes back from work, she will be working at home, helping out with cooking, with cleaning, with getting things ready for the evening. So those are, for me, that's been the most fascinating part of developing the scripts for the standardized patients, which is unlike a regular survey, unanticipated things will happen. And the job of the training and the job of the standardized patients is to come up with a script together with the researcher that both is honest to the life of the patient you have developed and the biomedical aspects of the case. So let me stop there and hand it back. Thank you.
Thanks, Jishnu. And that's sort of, I was just thinking about sometimes when these have been used in the US, professional actors have been used, haven't they? And there's a sense of there's a degree of getting into character and being, and sort of helping the standardized patients themselves, the data collectors, to really get fully into character in those ways that give that alignment between the case and the person. Really important. So I guess I've sort of been watching the questions and thinking a little bit also about where do we need further development of the methods. So in a way, and I've also been sort of making notes about how these studies have been used. So across all of our panels, we've had a number of studies that have kind of described a problem and used it to use the method to establish how much misuse there is of antibiotics. We've seen some studies that have been kind of in the middle around doing surveillance and changes over time. So the Kutub study looking for, so in a sense, the variation has been the implementation of the private sector TB strategy. And then with Jess's example from Tanzania, there was actually a trial with an intervention to improve quality of care. So maybe I could come back to each of you and ask you to answer one of the following questions. Do you think there are areas where the method needs further improvement? And then another question is really about how do we use these results to improve quality of care? So how have policymakers or providers responded to feedback from these information? So let me go back. I'll start with Milan. You might want to say something about the feedback from South Africa on the antibiotic use, but I wonder if you have any other examples of feeding back to providers their results.
Yeah, thank you, Cara. So on the improvements first. Well, I think there are a couple of things that have come to back over and over again in our discussions. The first one is, I think we've been sort of a bit frustrated at times by the number of limited cases we've been using. And I think, we know why this is the case. We know, that there are a number of constraints that we can't, we cannot escape. But maybe, I don't know, maybe, there would be a way using, working with actual patients or maybe developing new cases in some areas. For example, I know that in China, they've been using mental health. I think mental health is definitely an area where standardized patients could be of very, very high value and have not been used that much. Mm-hmm. On how can the results from standardized patient studies be used? So in our experience, so both in Senegal and South Africa, where we've had feedback sessions with practitioners and policymakers, I think standardized patients are incredibly well received in a sense. I mean, they're sort of an incredible way to open up the black box of consultations. And I mean, they can be controversial at times if they sort of put on display some behaviors or some practices that are really not necessarily seen as bad by practitioners in particular. So in South Africa, I think there was an understanding, or people were not so surprised at the level of misuse of antibiotics. I mean, they were quite horrified by how high it was, but they weren't that surprised. However, in the private sector, they were also using lots of steroids they were giving lots of steroids to patients, and being sort of told that this was really not an acceptable, correct treatment was not necessarily well received by private practitioners who had been using that and who were really seeing that as a way to make patients feel better, as they put it to us. And so I think it really provides a great basis to discuss with providers, to discuss with practitioners on the problems that are very clearly highlighted with great certainty, and then discussions that forms the basis upon which we can discuss, okay, well, how can we then move on to design interventions or to do things in order to improve practices. And we've been in discussion, for example, in South Africa with policymakers to try and design an intervention to reduce unnecessary prescribing of antibiotics.
Okay, thanks, Milan. Roman, 1 or 2 minutes from you. You very helpfully pointed out the need for better reporting guidelines. Are there any other methods in your experience, areas where the methods need further development? Because I think you haven't yet started reporting back your results to either to policymakers or providers, have you?
Sure. First of all, I actually put my camera on, but for some reason it does not show up. I think method-wise, we are not. For today's workshop, we did not really spend more time on how to use standardized patient to do experiments. I think that's a new area. That's an area which are worthy of a lot of innovative exploration. In the past, most of the experiments are focusing on antibiotics use, but it can be used for other situations, and we should come together to think and innovate methods around that. Secondly is the standardized patient validation studies, by and large focusing on detection ratio, but that's only dealing with one aspect, a Hawthorne effect. Other than the other aspects, whether or not they are playing accurately by the book, whether the orientation of the everything is okay. How can we come up with the validation standardized methods to validate our cases? In terms of how to use the results to improve the actual care, and that's absolutely very important. We got commissioned by an insurance company to do standardized patient assessment of high-end facilities in China. And the results can come back and can be used to inform the customers in choosing providers. But I think that's a double-edged sword, as the clinicians may like it or not. Many previous studies have suggested audit and feedback is a very important tool to improve efficiency. I will stop there for the interest of time.
Thanks, Roman. Jishnu, 30 seconds left for you.
I think the main gap and development that we need to work on is how to introduce repeat patients. So doctors often say, try this for a couple of days and come back. And the problem is your one standardized patient expands into 10 standardized patients if they visit 10 doctors. So we've tried a small pilot on it. It's really, really hard to do. And I think that's kind of one area with this dynamic nature of the treatment that becomes quite interesting.
Thanks very much, Jishnu. What a rich set of experiences. Thank you very much, panelists, for sharing. Virginia, I'm going to turn back to you to wrap up.
Thank you, Cara. Thank you to all the panel members. It's been a whirlwind tour, but I think we hope that for those that are starting to explore SPs, we hope that we've stimulated interest and ideas. We've introduced you to leaders in the field. We've also heard from people who are just getting going, and they've revealed the sort of issues and challenges that they've been facing. We've gone through practical steps. We've highlighted issues around ethics and also the importance of training. And also asking people as you go on this journey with SPs, or if that's what you're doing, is to document as much as you can the process, as much as the empirical results, so that others can learn from your experience. And in terms of that, we're very fortunate to have papers like the ones that Jess and her colleagues have published, the How to Do paper, and of course the manual from Jishnu, Ada and colleagues at the World Bank. That's just an enormous contribution to the field. So thank you to everybody that's taken part, and the questions have been just spot on. Cracking questions. Thank you very much. You've really got us thinking. You've challenged us. Ada, over to you to say goodbye.
Yeah, thank you, Virginia, and thank you to all the panelists and presenters and Kara for chairing that last panel. It's been a really rich discussion today, and I think what we will do is I'll invite all the panelists and the presenters to visit the website, and I think we'll all try to answer the pending questions in the next coming days and weeks. Thanks again for everyone, and apologies for all the few minor technical difficulties. And thank you. Have a good day, everyone, night or morning.
Thanks, everybody.
Bye.
Bye-bye, everybody.
Thank you.
Bye-bye.